Hello and welcome to Newsnight. I am Ladi Akeredoluwale. It's our pleasure to have you join us for today's edition. The spread, as well as efforts to contain the most recent manifestation of the coronavirus, that is COVID-19, is still front and center worldwide. With more than 300,000 confirmed cases, sadly, more than 12,000 deaths, but happily, more than 80,000 recoveries, it is number one on everyone's mind. In Nigeria, a creeping lockdown is now well advanced with orders to shut schools and airports, amongst others. Is this going to be enough? What else should we be doing? My guest is epidemiologist and public and environmental health specialist, Professor Adebayo Onajole. Prof, thank you so much for your time. Welcome to Newsnight.
Thank you for the invitation, and it's nice to be here.
Now, we seem to be now somewhat taking this issue of COVID-19 a bit more seriously. There are restrictions, airports are being closed down, external flights are being restricted, schools, religious places, all that. We'll come to that in the course of the discussion, but maybe the first thing to ask is, would you be one of those who would say we ought to have acted sooner than we did?
I would say that we've always been acting long before it got, received the first case. As far back as January 2020, there has been a lot of meetings and planning in place. This is what we call the silent phase. The silent phase of an epidemic, or preparedness for an epidemic, is that time when you keep on putting things in place long before the occurrence of the very first case. And that in itself helps to mitigate the number of cases you do see. So for the public, because a lot of them are not aware of the silent phase, which though, as the name suggested, silent, they should not also be aware. So the tendency is that they think nothing is being done. But the silent phase is meant for professionals. It's meant for the key target people in place. And I will tell you that not only for these coronaviruses, there are a lot of improvement in our surveillance and disease notification system at every level in the country. And it is not every disease condition that you pick up that you go to the media. What will result? Panic, unnecessary panic. You remember during the Ebola issue, they used to saying that somebody ran into a compound and shouted, "Ebola, Ebola." And some few people jumped into the well. What killed them? It was not the Ebola. It was not giving appropriate information at the appropriate time. The information that is meant to be given, our action taken, must be appropriate to how the experts are perceiving the trend of the disease, rather than creating chaos and therefore worsening the epidemic situation.
If we had all this preparation and we had all this planning, how come? Because if you take a look at the breakdown of the cases that we have, a vast majority of them are from returnees, and the balance are from those that those returnees got in contact with after they returned. So the argument goes that if we had maybe done the shutdown a lot sooner, many of these people would not have had access to the country and the opportunity to come in with this virus.
Reaction and measures are always taken based on the experts' opinion of trend. Even countries with advanced surveillance system still had cases coming in, yes, and they were reporting cases even worse than what we have reported. What you see, one of those things that you do not shut down the system. You don't cut your nose to spite your face. You must study what the trends are. You must look at the situation of things before you take those decisions. You see, you do not say, okay, I will give you an example. We'll be having Lassa occurring in this country. Why don't you have what you call silos shut down? For example, shut down the whole of Edo State because a lot of the bulk of them comes from that area. Yeah. They cannot move to Lagos. But that will not be scientific enough. You need to look at disease occurrence. You need to look at disease trend. And you need to look at a lot of other things and then decide that you want to shut down people's life. Because when you shut down people's life, it is not only the disease condition you talk about. You're also looking at other aspects of their lives. And the economic aspects, you look at people who are daily paid.
Right.
If they don't go to work,
they don't earn anything.
They don't earn anything. Hunger will drive them out at the end of the day. So decision of just closing borders or shutting certain areas off without scientific proof will not be advisable.
Now, at the stage at which we are now, that is being done now. We're shutting down schools, we're shutting down borders, as it were, land, sea, and air. We're increasing surveillance. We're asking people not to gather in places. Those who can work from home should work from home, and all of that. We're doing almost all of that simultaneously. At this stage now, coming from where you answered the last question, what is the basis for it now?
The basis for it is simple. We are looking at the trend in other countries, and we're also looking at the trend around us, the countries around us. Based on those trends, you are able to give that kind of advice of shutdown. Okay. You see, when we talk about one of those unfortunate things is that when you have one case of COVID-19, you have 10 asymptomatic carriers, which you cannot differentiate from A or B.
What is an asymptomatic?
Asymptomatic carrier, those people who can transmit the disease condition, but will not manifest with signs and symptoms. So when you have that kind of situation, the only thing you want to do, if you say you want to have a complete shutdown, is that nobody should go out, nobody should move out, this market should not operate. In other developed countries, we have a situation whereby even food could be provided to your doorstep.
Yes.
80% of Nigerians are not working in any formal setting. They depend on their efforts to earn what they eat. So what do you say? That, okay, you say nobody should go out. There will be panic buying one. People want to
That has already started.
People will start stocking food. 2, increase in price, which make the disadvantaged population, the people who are called disadvantaged population are people who are, I use the word, they have poverty of the mind and poverty of the pocket. Poverty of the mind is about how they reason in terms of what is occurring. And poverty of the pocket is how much liquid cash they can bring out to solve this problem. And this set of people are going to be in a very disadvantaged situation. And they are the set of people who will end up helping to spread this disease condition, because there is no way you can keep them in one place. You cannot keep an hungry man to say this. The man will say, if I stay home and hungry, I will still die. If I go out, I will die. Let me go out and look for what I will eat and die. So those are some of those reasons behind not really having a total shutdown. You see, some countries that have what we call a total shutdown have social services in place. They have records to know who is where, what is that, what you can supply to them. The only thing is that if you have a social shutdown in this part of the world, after about 4 weeks, what will happen is that you're going to people's home to pick the dead bodies from hunger, not from
the
disease condition. So you need to balance this information before taking decision. You see, it's not always easy to take decision at the very top, because you have to balance so many factors that may have a role to play in the situation. But I will tell you that for the health workers and people in the epidemic area, they've been strengthening, even before we had the first case, they've been strengthening training of their health worker, disease surveillance officers. They've been improving on notification methods. They've been improving on rumor management. A key issue in trying to control this epidemic per se is the management of rumors. People either being mischievous or want to be relevant or whatever it is, shun out information that it themselves know they are not true. A lot of people forward information that if you ask them to read it again and make a decision, they will say, oh, you can't believe it. If you know you cannot believe it, why do you forward it to create chaos? And these are the issues that we are having in place. The panic measure is even preventing a lot of people from doing basic things like hand washing, like social distancing. And also too, because our country is also a very religious country, everybody will say, it will not affect me because I have faith. We must know the role of faith and religion and the role of science and disease causation. We must always be proactive. The government has their role to play. But even as of now, the government is doing a lot of what they are supposed to do. Are the individuals doing what they are expected to do? Those are the questions they have. Because disease condition and disease spread will start from individual first. Before it becomes a community problem, before it becomes a national problem. If each and every one of us take basic hygiene properly, we go as long as 40% in reducing the spread of the disease condition. You see, one of the challenges we do have is that we expect people at the top or government at the top to do everything, whereas we are not doing anything to prevent or stop a spread of the disease.
Now, that brings me to something else now. Earlier on, you mentioned that there are people who may actually have this, but they don't display any symptoms, and they can spread it even though they have no symptoms.
Yes.
And therefore, you do not get to know that it is them who is spreading it. Your attention may be focused elsewhere.
Thank you. Yes.
Now, if that is true, that brings in the issue of testing. The issue of testing people submitting themselves to be tested, just to be sure. How are we doing in terms of testing? Because so much noise was made about that we're not testing people. People are not making themselves available for testing. Even people who travel and come back from risk countries, up until maybe a few days ago, they were not submitting themselves to test. The forms they were asked to fill at the international airports, they were providing wrong information, wrong addresses, wrong telephone numbers, and so on, deliberately in some instances, as it was found out. Where are we within that mix? Because yes, the number of cases we have confirmed are still small, but perhaps could they be a lot higher if a lot more people were to subject themselves to testing?
The issue of testing cannot be arbitrary. The reason is simple. The kits are not available. And we do import a lot of these kits. Most of the countries where you import them from also have their challenges. So they are not ready.
When they don't have enough
for you to start sending kits to this thing. And that's why you must use what we call discriminatory medical experience to determine who you are supposed to test and who should not go for tests. And that is also why we have to also use case of what we call contact tracing. And if I will tell you, the issue of contact tracing was one of those key issues we did use during the Ebola epidemic.
Yes.
Because you see, if you have 100 people that you are coming for tests and you have 10 test kits, how do you approach it? Do you just give it to any 10? So you want to look at certain criteria why you ask one person to go for a test or not. So, and that is what is being done as it is now. 2, coronavirus is not a test that every laboratory can do. There are only very few specialized laboratories. So the kind of people who you want to collect the specimen And how you send the specimen to the lab must be through trained individuals. It is not like malaria film where you can even do your pinprick and say, I'm doing the test. That is why the tests cannot be just for anybody. But they are important. So, and that is why, as part of the problem, they make all airlines to give forms for people to fill. The fact that people are filling wrong information, the fact that people are giving wrong identities will not be blamed on the system, is that the media also lead to educate individuals, families, and communities that when they give wrong information, they are exposing not only themselves to risk, but their family, their friends, this thing, and that whatever goes wrong comes wrong. When you look at the screening process at the airport before the airports were closed now, they have two lines of screening. One of the key issues of temperature is the temperature measurement.
Right.
Because when you have the state of viremia, that is, the virus is multiplying, it tends to cause increase in body temperature. And you tend to use increase in body temperature as one of the indicators of isolating or selecting individuals that you request to go for tests or not. It does not imply that other disease conditions cannot cause elevation in temperature. Malaria, for example, which is endemic in Nigeria. So, and that is why we also have a second line screening, even at the point of entry, whereby these individuals are reviewed if there is temperature increase about so many other things which are indicators before they decide on should we quarantine, should we isolate. Isolation is only meant for people who have already tested for the disease. Quarantine is for people who you suspect may have been exposed. The word there is suspect to have been exposed to the disease condition. And based on the suspicion, and that is one of those things why we are having what we call self-isolation or quarantine. We are also thinking, they have also thought about community quarantine, where if you suspect a community may have a higher incidence of being exposed, you limit people from those areas from moving. And that was what was done in Wuhan, China, that people were prevented
from moving,
from going out of that city
or coming
in because it was seen that the epicenter was there. But in this, what we only had was a case at the initial stage. It would have not been proper for you to say everybody in Lagos, including you that is taking this information now, cannot go out, cannot go in. Because you need to establish that the quantum is much. And you see, you must always use statistics most of the time to decide whether you have to deprive a larger people their individual liberty or not. You cannot use one single incident and say that you deprive a lot of people their individual liberty. So those are the issues that are there, which when the experts who are discussing those things will discuss about, but the common person will not be exposed to those information. They will tell you that even if it's one case, you should just close down. Everybody should stay at home. Nobody should go to work. And the question is, have you been able to establish that there is community transmission? Have you been able to establish that now that we are seeing some cases from communities, and that's why the government now is taking those measures to say that now that we are seeing people who have been in contact with people who are, let's try to stop people from this thing, because most of the cases we have always come from outside the country. Right. A lot of people go to countries where you say they do not have not reported the case, but their transit position, they pass through airports. Right. Where this thing, because if you are going through BA, for example, you go through Heathrow. Right. If you are going through Emirates, you go through Dubai. At the point of aggregating these individuals, they come from diverse positions. And it may not be able to say exactly who is coming from what, except you see the trend. Now that we are noticing the trend, we know that most people we have seen have come from sometime in UK especially.
Yeah.
So if you say, oh, airlines coming through the UK should be stopped, you'll be justified. But we now discover that some people take airline from UK that goes through some other transit position before getting to Nigeria. And that's why they have gone further to say that let's close the airport. Everything must be based on the trend that you see. You study what is happening within your own country, you study what is happening with countries around you, and you study what is happening in the global village. And every of this information we must look at. There has been swine flu in the past that never came to Nigeria. That was China and co. Do we, because we had that China has swine flu, we should shut down here? And unfortunately, we never had many severe cases of swine flu or epidemic at that point in time. So these are part of the reason when people come out, when I call the laymen, they come out, they become so emotional, and they want to say, yes, they should have done this with the spirit of hindsight. You can always remember that when they are playing football, everybody watching is a coach. And every one of them always think that a player should have played better or this thing.
We have heard repeatedly that some people are more susceptible than others. And you can correct me if I'm wrong. The general information tends to suggest that older people, one, then people with pre-existing conditions, such as respiratory issues and so on, are more susceptible to the COVID-19 than others. And that, in fact, a lot of people have recovered from this, even as we speak. Statistics I have from Johns Hopkins University, as at March 17, there were about 10,000 people dead. But there were about 80,000 people who have been treated and have recovered. And of course, they did the profiling. But can you explain to us this aspect of people who are particularly susceptible, who are more susceptible to it?
Not only for COVID virus. You are taking me back to basic epidemiology.
Okay.
In basic epidemiology, we teach our students that we have what we call epidemiology as to the person, characteristics of the person, characteristics of the place, and characteristics of the time that makes individual to be susceptible to one disease or the other. What you just mentioned is what we call characteristics of this person. You see, for the person, there are certain disease conditions whereby certain age groups are more at risk. For example, pneumonia. Younger and older age groups are more susceptible to pneumonia. And COVID-19 is a type of pneumonia. It affects more of the respiratory tract. For elderly people, most of their respiratory tract or aging processes too will have taken place. So when you have a disease condition that is going to cause inflammation, the inflammation may be so rapid. Some of the respiratory system may already be damaged due to other disease conditions these people have passed through in life. And when they are not exposed to this thing, they easily succumb. Age may also affect your level of immunity. Your state of immunity may also, your state of nutrition may also affect people who are already malnourished, have depressed immunity. So if you expose to one little disease that will not cause any severe disease condition in others, those people might easily succumb. And you know, in elderly people too, they don't eat well. Their nutrition is poor. They have lost a lot of appetite. So it's possible that their level of immunity may also have been affected. And that is why they have this thing. I was listening to a video, something from the Defense Minister of Israel. And he's saying that from their own studies, older people are more exposed. So parents should tell their children, younger people to stay away. But they should take care of them, bring food to their doorstep and wipe up everything so they can come in and pick it up. And that by the next 4 or 5 weeks, the younger people who have better immunity will have been exposed to subclinical infection, and else will have developed some level of immunity. And therefore, when their immunity is improved, the more severe case of COVID-19 will have no effect as such. Coronavirus has always been there, even as I was a medical student. So it was not as if, it's just that the serotype that we are now having now is more viral, more distinct,
more dangerous
than what they used to have. And that is what we're talking about. So when you see, even when we conquered this epidemic, there will always be another epidemic. So we must change our attitude, our sanitary behavior, our environmental health attitude, the way we manage our refuse, the way we manage our sewage, the way we take our portable water supply, availability of portable sanitary facility for the general populace. So that people stop passing feces all over the whole place, urinating all over the whole place. These are indirect way where disease condition can be spread. Today we are looking at COVID virus. We are talking about respiratory issues. Tomorrow it could be another disease condition. So we must have what we call a generic prevention to disease occurrence. We must learn how to take care of our environments. We must learn how to dispose and cut our refuse properly. We must learn how not to cough in public, learning to cough either in your elbow or in the handkerchief. We must learn that when we talk, we should not talk so loud or something like that we're spreading our spit all over the place and people are inhaling it. It may not be specifically for COVID-19.
That's a general practice.
As a general practice, we're saying that. You remember during Ebola, every organization put on the hand washing something. After we finished it, what happened? Everybody went to sleep.
Business as usual.
And then we are waiting for the next one to occur. And then when the next one occurs, we start shouting again. Now they've talked about churches and mosques to close down so as you do not prevent crowd from accumulating. But some people say, no, they want to break services to 5. And the people are going and coming and meeting themselves on the road. And the contact and social distancing has not been critically enforced. And because of that, we are not solving this, because some people, either because of their ignorance or because of their spirituality, they think they are immune.
Now, we have taken some fairly drastic measures. As you pointed out, the closures, the restriction of interaction, social distancing, and so on. But enforcement appears to still be not quite total yet. And because of that, there is still the fear that if we are not doing it the way we ought to do it, we may not get the results that we ought to get.
That is true. The truth is about, like I mentioned earlier on, prevention starts from the individual. Government will only give you a blanket policy. It will not be in a government place or should be in government place to be policing. Because by the time you start policing, sending a lot of enforcement agents, you are also getting crowd. Is that not so? So we need to prevail on individuals and social leaders, political leaders, religious leaders, to try to protect their members. They can only be leaders of their assets only if they are alive.
Where are we on the issue of medications that can be used? Because you mentioned chloroquine. A lot of people, of course, went for chloroquine because they heard that it may have been. But are there any drugs currently that can be used to treat this?
I will answer you that question. What do we call the disease condition? Coronavirus. We've had drugs that are being used for a lot of virus infection. And what could be done now is to have a combination of some of these drugs. They are not antibiotics. You know, antibiotics is for antibacterial.
Right.
This is a virus. So we have antiviral drugs. For example, a lot of drugs are being used for HIV. Some of these combinations could be used additional, but because some of them, the combination may be in experimental stages. When I say use the word experimental stages, it's not as if they may not function. But by the time you mix them and the person recovers, you see it has worked. But again, too, I will tell you that most disease condition, especially viral disease condition, is self-limiting. Self-limiting in the sense that it's either you die off or you recover and you are fully okay. But one of those things they give drugs is to manage those symptoms so that you do not it do not treat you to that stage where you will die. And you have many more people that are recovering. If you look at the statistics, compared to a lot of people who die, many more people have the infection and recover. 2, many people who die also have other debilitating health conditions.
Which this just accelerated.
Which was accelerated by disease condition. 3, you will not just look at the disease condition, the individuals, you need to look at statistics on base of what has happened. Because if it hasn't happened, there's no way you can say older people will be more exposed than younger people. Or that under 5. For example, in management of malaria in this country, we tend to focus on the 5 and pregnant women. Because from studies, it's been shown that those people are higher risk than the general public. It does not mean
that the general public doesn't have any risk at all.
That's what I'm trying to say. So, based on what we'll keep on learning from this occurrence, this is the first time disease occurrence that there's no way we can have a deja vu experience to say that this set of people are likely to have it or not. Based on what we're learning on time or real-time learning from what is happening around us, we make certain decisions. But not based on, I feel it's you. That should not be. A scientist should not say, oh, because I feel, therefore, this, because it has what we call a multiplier effect. And decisions will be taken based on data available. Based on, a lot of people are working on a daily basis, looking at the trend, looking at the occurrence, where it's occurring, how it's occurring, who is affected, and so many things. And based on those things, you know that statistics deals with number, not with individual. And when you have these statistics with numbers, it's only when you have the numbers that you can say likely. Even when we give prognosis for disease condition, sometimes we say somebody is likely to survive 5 years and the person dies in 6 months. And somebody say, oh, you are likely to survive, you won't last more than 6 months and you live 2 years. It's based on experience of the number you've seen in the past, and that people who have this kind of condition are likely to die like this. So, but when you want to translate it to an individual, you must be very cautious in translating population data into individual data. To say that because I have seen, if you have this disease condition, it's a death sentence.
The situation where, yes, all attention is focused on COVID-19, coronavirus, and so on. But before coronavirus arrived, earlier in the interview, you mentioned Lassa fever, which were things we were already dealing with before this arrived. There were other things. Nigeria has the highest chunk of tuberculosis deaths, even as we speak. Yeah. Now, that is a respiratory situation, which this could actually bring quite a number of the people who are involved in it to the point where you say it then leads. Now, what would you say, or what do you think should be done? That because even while we are dealing with COVID-19, there are these others that we were currently dealing with before that arrived. Are we taking our eye off those ones while we are dealing with this?
My own opinion would be that there are populations that are at higher risk, tuberculosis population, like you say. They should pay special attention to them, especially in issues of distancing, aggregation of population, because they already have certain conditions within themselves that is likely to make them to be more prone and have more severe end points as compared to the general population. Two, we will not and cannot stop attending to those special disease conditions because they still exist. And apart from they still exist, they will also add to the mortality figures of COVID-19 and give us the impression
that it's actually killing more people than it is killing.
Yes. So one of those things that there is a need for more re-education of health workers first, because they cannot run away because there's COVID-19 now. And you have all these other disease conditions and say, I will not take care of them because there's COVID-19. So they need to reorientate them. Two, we needed to realize that hospitals are disease supermarkets. I use the word disease supermarket. Like you always realize, what is a supermarket? That is where you get different type of goods. And a hospital is a place too where you get different type of disease, both diagnosed and not diagnosed. Hospital managers must put a lot of effort to keep on protecting and educating and retraining their health workers. Because whether they like it or not, they always be on the front line. In some disease conditions like Lassa fever, the people who have been bearing the brunt more of the outcome of disease is the health worker. Because they bring one patient and 4 health workers die. So we need to also look at it from that point of view, that the hospital setting is a special population whereby we will need to put in a bit of more resources to provide essentials. When I mean essentials, what are the simple essentials? Running water, soap, sometimes face masks, if there's a sometimes protective equipment, if there is need for it, to be available for this set of population, because their risk is 10 times higher than the risk in the general population. The next other population is people, the community. The community must take responsibility of protecting themselves and their family, rather than waiting for any law. Even the government did not ban. Based on what they have learned from the media, they should be proactive and protect themselves. Like I always tell a lot of my students, I say you must never be part of statistics, because the world will only remember the number, not the person. So you must do everything possible, and everything means a lot to protect yourself while you are still doing your work.
Now, there are those who will look at you as you were talking, and they will remember that you had mentioned earlier that this one will come and go.
Yes.
And that others will come.
Sure.
And they will shudder when you say things like that. Is that the normal way it's supposed to be? That people, that, you know, these kind of things will come and they will go. Regardless of what else we do, they will come and they will go. And therefore, we need to adjust ourselves to the reality that this is what happens, you know, as a matter of principle, normally in the course of human existence.
If you go historically, it is the usual. Cholera has been like that until they develop vaccines, until they also improve on oral radiation, a lot of other things. But the key issue that will be permanent is what the individual keeps on doing. So we must, as a constant, as a matter of habits, as a number of principles, to improve our lifestyle. As of the time of Hippocrates, it's always saying that, or it was said that, when you see a disease condition, ask for where the person lives, what food the person eats, what source of water and the air the person is breathing. That has been there from BC. And it's still relevant now. And that tells you that there was a time, I will tell you, that syphilis was a pandemic in a part of a country. There was a time smallpox was serious, that even in our own place, they have a name. They think it was the gods that caused it. And therefore, they go and gather together to appease the gods, only for more people to be exposed. So these are issues that we must learn to believe and trust technocrats who advise us, like they say, social distancing. Do not aggregate in numbers. Even the word they say 20, like we won in 20. Who among those 20, one of them may be carried. That means that those 20 will go back into their community and get another 50-ish. Look at the multiplication of that. So you see the issue, like some places in America now, they are doing their services online.
Yes.
They are following it up just for the time period. And people are getting it. But I hope people, for whatever reasons it is, wants to bring you together. I mean, even some churches now are still giving, what do they call it now?
Communion.
Communion in the process. Other churches have stopped. And we have been told that this is spread from one person to the other. Imagine you taking a Holy Communion from one cup, the next person comes in. If you had it, you will have transmitted it to the next person. And this person, you see, one of the challenges we have is not about the people who have symptoms. It's about the people who do not have symptoms. For example, you have a person A who starts manifesting with a cyst, who has been exposed. This person say, I'm going to visit a person C. In the process of going to see a person C, is going to pass through a person B.
B, yes.
Who does not know him, he does not know the person. He will see, if they were doing a contact tracing, we will see the person A. Who did you see? He will tell you person C. But he will not mention
person B.
Person B. And the person B already become a spreader or someone who can disseminate the disease condition. And those are the kind of the challenges you do have when you have diseases that are airborne, that you can spread through those routes.
Now, as we wind this down, I want you to finally, looking ahead now. We have talked about where we were, where we are, but now to take a look at where we want to be. There are those who would say that if you believe the seers, those who saw tomorrow, because in the run-up to this, I've seen some write-ups, some quoting Nostradamus, others quoting Kuntz, who is a well-known author, saying that this will come, and just as it came, it will disappear, and then it will return, and then go again, and that will be it. Now, those who read that tend to be a bit more relaxed about it. Whether that is true or not, that's a different thing. But going forward, you've mentioned a number of things that we need to keep doing, even after we overcome this particular episode. Yes. Now, but other than that, at the level of capacity, what you started off by talking about, when you said, look, we need to talk more about increasing about our capacity to treat things, to deal with things, and not just leave them to when the crisis erupts. Please talk a bit more about that as we wind this down.
A lot of preventive acts are done in what I refer to, again, as a silent phase. A silent phase involves multidisciplinary setting, you see, one, giving the right information, appropriate information, not over-information and not disinformation and not under-information to the general public. That is why there is a need of training and retraining. Health correspondents, people in the hospitals, health workers, people in disaster management who are going to be on the front line in terms of an emergency. There is always a need to train and retrain these people. I'm aware that Lagos State is doing a lot with respect to that for the different sub-organizations that are involved in some of this frontline emergency management. Though the general public do not see it as being done, because people always believe in what we call the knee-jerk reaction. People always believe in making so much noise and doing nothing. But then it's not going to be limited, it should not be limited to Lagos State. Lagos State is well endowed in terms of manpower in all these facets. But all the states should also learn from Lagos State. Look at where we started this coronavirus epidemic. The first state, the place we used for Ebola there that was built properly and everything like that, was not maintained. And so they had to start rushing again. We must always be what we call, like the Boy Scout says, be prepared. You know that today is Ebola, or Lassa fever, or is coronavirus COVID-19. Tomorrow, it could be under big disease condition. It doesn't have to be this disease. We battle with Ebola, we are battling with Lassa fever and dengue virus, which are still occurring. We also been battling with cerebrospinal meningitis. Those are disease conditions which are still, we have not even been able to conquer them. So that's more reason why we must put in place 3 specific measures that must at any point in time not be abused, not be stepped down. 1, our system of disease notification, we must keep on strengthening it. Our system of disease surveillance must be enhanced so that we can be able to pick out early enough. Because the earlier you pick a case, the more likely you can prevent many more from occurring. And then the other third prong of this is our system of rumor management.
Rumor management.
Yes.
Can you expatiate?
You see, because of the social media today, some people either being, for whatever reason, pass disinformation. Things that does not even occur here have brought in here and cause a lot of panic situation, create a lot of situation that now expose more people to danger that it should have been. And then if we do not manage it well, that is, when we say issues like this, there must be a desk that when things are not too clear, should be addressed to those desks quickly, and we have a position on what is the correct thing. So that people should not start multiply effect of sending information that are not true and putting many people in danger. That's why I said our system of rumor management should always be there at all times, and we must always learn to abuse it rather than ignoring it. AUJ, all the people in the other areas must also try to keep on educating. And there must be what we call an interface between health correspondents and technical health experts. Because there are some technical jargons that you could misinterpret in so many ways. But if you do not understand and you have access to technical health experts, they will to break it down to what exactly is that jargon meant, and you'll be passing the right information to the general public. So these are issues I think will help us a lot to manage this COVID-19 and also to manage many more epidemics that will occur, whether we like it or not. It may occur from our own country, or it may occur from every other country. You know, it's said that we are now in a global village. Yeah. You can take your breakfast in Nigeria and take your late lunch in UK. So that means that if you're already exposed in Nigeria here and you're equating, you only get to UK to spread it, and vice versa.
Prof, thank you so much for your time. It was a pleasure speaking with you. Thank you very much.
Thank you. It's been a privilege and an honor.
That's today's episode of Newsnight. Thanks for watching. Would like to know what you think of the conversation. Our handles are right there on your screen. I am Ladi Akere Goodbye.